This is the Whole Care Network. Helping you tell your story one podcast at a time. The following Care Lab podcast does not provide health or medical advice. All content is provided for information purposes only. Listeners are encouraged to speak with their healthcare provider for specific healthcare advice and are wholly responsible for the outcome of implementing any tips or information presented.
Welcome to Care Lab.
Welcome, everyone. This is going to be a really, really good episode. So I hope, listen, buckle up, Buttercup. Let's get ready.
Right.
Let's do this. We have here with us Dr. Brittany Lamb. She's back again for another episode. So thank you so much for being here.
Thanks
Brittany,
for having me.
I'll let you give yourself a little intro here if you don't mind.
Yeah. So just briefly, I'm an ER physician. I also recently started a hospice medical director job, so I'm kind of new to that role. And online, I help people navigate medical decision making on behalf of someone that they care about and are advocating for who's living with dementia. That's what I do.
So what you're saying is you really don't have much going on. You're not a busy person.
I was just about to say, you do all the things, actually.
Yeah.
I wear a few hats right now, and it's working. My husband's still with me, so it's okay.
All right. Good for him. Pat on the back for both of you. Okay, so it's November. I'm going to say that we're in full holiday swing at this point because, really and truly, if you go to like the Home Depot or the Lowe's where I live, then the holidays start in September anyway. So if we're in November, we're in full holiday swing. I have a question for you both before we jump into the nitty-gritty, deep dive we're going to take on hip fractures and broken hips today. Okay, are you ready for it?
Mm-hmm.
Ready.
Okay, this is such a softball, actually. What's your favorite Thanksgiving Day tradition? What's your favorite?
Go ahead, Brandy.
I guess I'll let you pass it because you've already been a guest, but really, we made the guest go first.
Yeah,
but
yeah, we're usually
I'll go. I
we're
will
usually
go.
rude like that.
Okay, Thanksgiving is pretty much my favorite holiday. So I have lots of traditions around it that I like. My most favorite, I think, is not very surprising. It's like eating.
Mm-hmm.
I just like to eat dinner. I like Thanksgiving dinner. And I like all the things about it. And I make some of those dishes at other times during the year. But this is the time I get to eat all my favorite dishes at one time. Gluttonous, I know, but it's awesome.
Do you have a favorite dish? Maybe that should have been the question to begin with, because obviously, we're all going to like the eating part.
I would say football, which I also like very close second to watch a lot of football. I like being with my family. You're like, no, not the football. But still, it's like it's sitting around and breaking bread together, I think, with as many people as I can have in one place is awesome to me. And hopping from house to house and seeing even more people, that's like the thing I love the most about it.
I love that. Yeah, I'll chime in here. So, my favorite dish is stuffing. And my husband and I argue about the stuffing versus the dressing and the stuffing. My grandmother's stuffing is the best. That's the best part of Thanksgiving. When I have to work in the ER, they save some for me so I can have some. So yeah, that's my favorite dish. And I would just second, being able to sit at a table with extended family and have everybody all in one place. When that actually is able to happen, it's very special and something I look forward to and feel very grateful for when it actually works out. So
yeah. Enlighten us. What is the argument about the dressing versus the stuffing? I want to know this.
Well, which is better, which tastes better, right? So I mean, I don't know if everybody knows the difference between stuffing and dressing, but like stuffing is breadcrumb based and dressing is cornbread based. And so I feel like it's almost like a North versus South argument. So it's just based on taste and preference, and the stuffing's better.
So that's really interesting. In my family, we define dressing as it's like stuffing, but it's cooked outside the bird, so it's never inside the bird.
Oh,
And like
okay.
that's a
Okay.
dressing versus like stuffing is whatever is in the bird. And I just like bread. I just like carbs of any form.
Carbs of all kinds.
I love carbs of all kinds. So I like zero judgment. Give me any of it, and then we'll put some gravy on top, and you know, all the goodness.
Maybe
I'm
that's
gonna
where
round this
stuffing actually. You're gonna round
I'm
it
gonna
out.
round
Okay.
these things out because I agree. Stuffing is inside the bird. Dressing is outside the bird. However, it's all made out of cornbread, ma'am. So we only do cornbread. We only do cornbread. It's all cornbread stuffing.
My grandma's dressing, which is the best, is made out of sourdough.
Oh.
So
I said what I said. It needs to be made from cornbread.
We're divided.
Sorry
here.
to your grandma.
I guess I like stuffing and dressing because I'll eat it if it comes from the bird or around it, but it's got to be breadcrumb based.
But so your aunt, you say no to the cornbread. Brandy says only cornbread.
Mm-hmm.
I say I'll eat anything, but my grandma's is the best, and it's made with sourdough. So
there you have it.
Yeah, there you have it. Everyone has their own way. I think other than eating, my favorite thing about Thanksgiving is that it's like a gratitude-based holiday instead of, and like a togetherness holiday. I mean, the best part of any holiday is really truly just being with the people that you love and care about, and like, you know, the family that you choose, whoever that is. That's the best part. But what I love about Thanksgiving is like that's really what it's dedicated to wholly is that gratitude and giving thanks and being with each other versus kind of you know, it's you get distracted on like obviously Christmas we got a lot of gifts and you know, actually I love Halloween. I've got nothing bad to say about Halloween. I love it all. Maybe a little distracted by candy, but I mean, what are you going to, I mean, it's Halloween. What are you going to do? But it's just this day where we're really just being thankful for things and kind of an opportunity to reflect and be with each other. And that's my favorite thing, but agree. It's one of the greatest, if not the best holiday, in my opinion. Okay.
So what are we really going to talk about?
We're really going to...
so that we can maybe get back on the same page, because I feel like we're very divided.
Yeah, we are. Okay, this has gotten contentious, people. No, so what we're really going to talk about today is actually like this is a pretty intense subject to talk about, actually. And that is, we're going to talk about hip fractures, also known as broken hips. A fracture and a bone that's broken, same thing. Same thing. And we're going to talk about why it is that they can often be so devastating. So, for example, you know, it's very easy. You can look up statistics on hip fractures and the outcomes for these things all the time. And we all know that people within 1 year of having a hip fracture can often have a very high mortality rate. So I think, you know, one of the statistics that's out there is, I'm going to look at it exactly right now so I don't misspeak. And this is from the Journal of Orthopedic Surgery and Research. The cumulative mortality after hip fracture within 1 year ranges between 20 and 40%. And the rates are higher those mortality rates are higher in men than they are in women. So if you think about
that means, let's break that down. That means that within a year of having a hip fracture and getting it fixed, up to 40% of people are passed away by then.
Yes.
Like that is very like jaw dropping if you didn't already know that.
Yeah.
So that's why it's such an important topic to talk about.
Yeah. And here's what I think is, on face value, that seems insane, right? Because a hip does not pump our blood. It doesn't oxygenate our blood. It's not responsible for getting nutrition anywhere, right? But this particular thing, if it gets broken, has these huge consequences. So I wanted to talk a little bit about why that is, to put out some good education on this topic and hopefully help some people, either prevent this or get through it in a way that where they're going to have a better outcome, because good outcomes are obviously really possible with this. So Brittany, Dr. Lamb, let's start with you. What happens? Someone comes into the hospital, they have a hip fracture. Like, what's the first kind of medical thing that happens for that person?
Yeah, I mean, I'd just like to say, I mean, it is pretty common. It's a broken bone that we see quite often, especially as people are aging, people who have low bone density, people who have even simple falls that other people would bounce back from can cause hip fractures. But when people come in, they almost always come in by ambulance. They're not able to put weight on that leg. They're in a lot of pain usually. People who are of a very advanced age or maybe living with dementia are super frail. It may be a little bit harder to figure out that they actually have an injury. But oftentimes you can tell on physical exams, or we're looking at their legs and one leg looks shorter. That's something that we sometimes will notice. But we get x-rays, we treat pain, and then we call orthopedic surgery. And then the other thing I'll say too is that we do try to figure out why the person may have fallen sometimes. Like sometimes it's not a very easy, we call it like a non-syncopal, non-passing out reason why they fell. And so sometimes it's a medical reason why people fell. And so we have to take care of that as well. But I think the big things are getting x-rays and then treating this person's pain. And obviously treating pain can be risky, and we have to do things differently with some different people. And one of the things that you all can ask for or be aware of is that nerve blocks are a potential modality for treating pain in people who have hip fractures. So especially if they're aging. So that's all I'll say right now.
What would be, because I actually think that's important, not to dive like too far down this rabbit hole, but what's the difference between a nerve block versus other types of pain management that people might traditionally kind of receive?
Yeah. So nerve blocks, you're actually injecting a medication that can make it so that that person doesn't feel pain in that area, like a regional block. So it's making it so they don't feel the pain based on an injection of medication, like a numbing medicine. And then pain medications, we typically are using things like narcotics. So we use morphine, fentanyl, Dilaudid, IV medications. Usually in the beginning, we use IV medications. Then sometimes we will give people pills in the ER, but that's not as common. Usually that happens when they get into the hospital. But those medications have side effects, right? They work in your brain. They cause sedation. They really are designed to make you care less that you're hurting. So that's what they do. So they work in the brain. So they lower blood pressure. They can affect people's breathing. And so depending on whatever medical problems this person has and how small they are and what their mobility is like at baseline, like some of these medications, it can be really, really hard to keep someone comfortable with narcotics while also appropriately treating their pain and not causing them further harm. So these regional blocks that typically, like where I work, the ER doctors don't do this as often because we're really busy. In some ERs, they might actually do this. And sometimes they'll call in anesthesia or like a pain team. Sometimes in the ER, but oftentimes that actually happens too when people get admitted.
Okay, really, really good information to know, to kind of understand like the difference between those things and how you might ask questions and advocate for either yourself or someone maybe that you are caring for who is in this situation. Good info to keep in your back pocket for sure. So, okay, so let's move forward in the process. Say we've got this person, they're stabilized, they are, we've managed their pain, ortho has been called, and let's assume in most circumstances, and this is something that you were saying even before we started recording here, Dr. Lamb, is that most of the time people are going to go ahead and have that hip surgically repaired, whether that's through a hip replacement or something that we call open reduction internal fixation, which is where we put like different kinds of hardware in there to hold things together. So we've had this done. What are then some of like the medical concerns at that point?
Yeah, so I mean, the biggest thing is what y'all do is like rehabbing the person so that they can get better and get back to their functional baseline. But complications after hip fracture repair, a lot of it is going to depend on the person's underlying medical issues. So we always have to consider that. But there's always a risk of infection. There's a pretty big risk of clots. That's something I see pretty commonly, clots in the legs, blood clots in the legs, blood clots that can then go to the lungs. There's also a risk of pneumonia in people because they're immobilized, they're not moving around as well. They're oftentimes on pain medications. Those are some of the big things. Infection, bleeding sometimes, like we have some bleeding complications that can happen, blood clots in vessels, and then infections. So infections because of poor mobility. So urinary tract infections, pneumonia, infections at the surgical site. I'm just completely riffing here. You guys know this too. So fill me in if there are any other things I'm missing there.
Hey there, it's Emilia. Listen, I am so thrilled to have a great resource like Ask Sammy as part of the Care Lab team, and here's why. It's a game changer for aging in place because it makes it so simple. All you do is ask. Just type in your question or even tell Sammy what the problem is and get tailored solutions. Everything from innovative adaptive equipment to comprehensive resources. It's a great way to become more empowered, to live more independently, and to live with greater confidence. And my favorite thing about how Ask Sammy works is it's deeply rooted in dignity and practicality. So whether you're a fellow therapist, a care partner, or someone who's seeking solutions for themselves, visit www.asksammy.com. We're going to link it in the show notes so you can find it there. Start making home more accessible today. Now, back to the show.
Well, I have a question. Is it more common to have blood clots after having a hip fracture, or you're saying in general after having a surgery, these are three things that are things that might cause additional problems? Because I guess what I'm wanting to get down to is like, people break their arm all the time. We don't have 40% mortality. So what is it that's like, what may be some of it? Because if we knew all the answers, we wouldn't have this level of mortality. But like, what may be some of the answers there?
I mean, it's a huge weight bearing bone, you know, so like people don't move, and you can still move your body around when you have a fracture in your arm, you know.
Mm-hmm.
So it's because of the impacts on mobility that are really the main driver. I mean, it's not what I do. This is just what I see, you know, what I see in the ER. So I don't study this. I'm not an orthopedic surgeon, but yeah, they're devastating injuries because they really impact a person's mobility. And to directly answer your question too, like any lower extremity surgery that somebody has increases their risk of having a blood clot. But people don't tend to get blood clots as often in their upper extremities when they have fractures and surgeries. It's just less common. Because, you know, you can still move your arms better than you can move a leg that's been operated on. So.
Well, and basically what happens, like the reason there's, and correct me if I'm wrong here, but the reason that there's an increased risk of blood clots forming when something isn't moving is because that blood isn't moving as much or as quickly through that space. And when blood is going slowly, it's then more likely to clot, essentially. Is that right?
Yeah. So the veins that bring the blood back to the lungs so that we can put oxygen in it. In the legs, there's gravity. So the blood's pooling because of gravity, because legs are hanging down. So they have to fight, the blood has to fight against that. And then when there's poor mobility, there's decreased return. Also because part of the way veins work is they get blood moved because the muscles are pumping against the veins and helping the blood get back up through the valves of veins. So your muscles moving around your veins is part of how you get blood returned back to the heart. So it's harder for the lower extremities, the legs. So
So all those ankle pumps that therapists are recommending and you feel like it's not very hard, so it's not very important, this is the reason. Because every time you do this motion with your foot, your calf muscle squeezes the veins and it brings the blood and everything else back up there so we don't have so much swelling and so we don't have blood clots. And like that's the purpose of that. I think one of the things that I think sometimes we as healthcare professionals don't do a great job of is explaining to people the why behind what we're asking them to do. And when you don't have the why, then you're like, I don't feel like doing this. It don't seem that important. I'm not doing it. I mean, I'm not saying that everybody's just like so blatantly like whatever. I don't care what they say, but like you're in pain, you're tired, you're in the hospital, whatever. Like there's all these other, you're not having your best day. So doing all this extra stuff that you didn't used to have to do doesn't always seem so appealing, but that's like the big reason for it.
Yeah. And so that's really one of the most important reasons. Like, if you have ever broken hip, if you've been in a situation where someone you love broke a hip, one of the things that you probably noticed was that almost as soon as your loved one is out of surgery, there's a therapist in the room there, and we're asking that person to get up out of that bed and go walk around, or at least get up to the chair. And it's because we know that the more quickly we get someone mobilized, the more we are, of course, getting them stronger and making it so that they can, live their life again. But right there in that immediate moment, we are also doing things like preventing those blood clots from forming. We're helping to prevent wounds from forming because you're not moving around as much. We're helping to prevent even things like constipation. Laying in bed, especially if you've got pain meds on board, is really bad for your bowels, right? One of the ways that we work, your body's meant to operate with gravity pushing from top to bottom, right? And that includes how our heart works, how our lungs work, and how our bowels work. And so we've got one of the most important things that we're looking at too is let's get you up. Let's go to the bathroom. Let's get all of these things moving. Let's get you positioned in this upright position where we're moving around so that we're working with the way that your body naturally wants to function in order to prevent these bad things from happening.
Well said.
Care Lab listeners, it's Brandy, and as the founder of a platform made to make aging in place easier for everyone, I knew it would be incomplete if we did not have education, especially for caregivers. So whether you're a family caregiver or somebody who trains a whole organization, Higher Standards caregiver training videos are for you. I'm so proud that we were able to partner together with Emilia in order to provide these to you because they're easy for everybody. You get great occupational therapist-led training on topics like transfers and how to care for someone as they age, or maybe as things change when you have Parkinson's. So no matter if you're the loved one who doesn't know exactly what to do next because things are getting different, or if you're a professional who trains caregivers that go into the community and you need some quality education, you get both from Higher Standards Caregiver Training. And you need to check them out at higherstandardscaregivertraining.com. So, okay, in this kind of journey we're going through, we've made it through. We went to the ER after the fracture. We stabilized it. Okay, now we got admitted. It's gotten fixed. We've hit our first kind of juncture of where there's risk, infection, pneumonia, all the things that you mentioned already. But the mortality issue is not just like at hospital level. It's for a year out. So then what are other risk factors that are happening maybe after we leave acute care that could impact your life expectancy?
Yeah, I mean, I think it's part of like what this person was like beforehand and then where they're going to afterwards, and what their journey looks like the next several weeks after they have a hip fracture. I mean, you guys speak to that too, like, because I see people when they have complications. So I see all the outliers, and I see the people who have high mortality. But I think so much of it is like what this person was like at baseline, like what age were they? Did they already have cognitive issues? Are they going to be able to engage in rehabbing and understanding, Are they going to actually get up? Are they going to be afraid of falling? And then do they have other problems that would make them at higher risk of having these complications? Like, do they have underlying immune suppression issues? Like, or are they living with congestive heart failure? Do they have COPD? Like, so it's a very individualized thing. The older someone is, the less mobile they are, the more cognitive issues they have, and the more medical problems they have. That's all going to impact their ability to rehab and recover.
So Brandy, I have a question for you.
Okay.
So, obviously, all the things that Brittany was just talking about in terms of like, there's of course are very straightforward patients that we might see who maybe they're younger, maybe they don't have any cognitive impairment. They're motivated to get up out of bed. Their pain is well controlled. Like, these are relatively simple and easier. They're easier scenarios to help rehab, right? The path to success is more clear there, and it's easier to get there. But a lot of times, of course, we are also working with people who do have underlying cognitive issues, whose pain are not well managed. Maybe they weren't as mobile as they could have been before. Perhaps they are very medically complicated. So what kinds of like tips or tricks have you seen or have you used to help work with those people and help them? I don't always know that motivation is the right word necessarily, but help them break through those barriers in order to get up, start moving, so that they can see that kind of like better outcome, not just in the short term, but hopefully in the longer term as well.
I think I'm going to say what I already said again, actually. The very first and most important thing that I think works the best is telling the why behind this. Because nobody wants to do any of this. They didn't want to break their hip. They don't want to be in rehab. They don't want to get out the bed. Nobody wants to do any of this, right? But they do want to be better, and they do want to be alive, right? And so if I can talk to, this is why it's really important that, yes, you just got out of surgery, and yes, I'm here to help you get up out of the bed, because all these other cascading effects happen. And so we're not going to solve all of that in one day, but we are going to be able to take a couple steps in one day. And I feel like that, like you said, motivation is not necessarily the right word. It's just like the ability to overcome all the other obstacles that are already in front of you for the longer term vision of getting back to your mobility, I think is the number one. But then the number two is like, that's only if you're cognitively capable of understanding that reasoning, right? And then if you're not, and the memory is impaired or whatever issue is going on, I think it's about community. And so that community might be your family that's there supporting you. It might be the other nursing staff. It might be other therapists and us working together to make sure that no matter what therapy they're in skilled nursing, that we're all working towards similar goals, using same words and doing things that we know works well with the person so that they can keep the ball rolling. It's all about all the other people that are around you, I think, and getting them all on the same page to be the most support in whatever form is necessary, because it is very individual for that person, so they can keep moving.
Yeah, I have to really agree with all that. I think that education is the foundation of any good intervention, period. Is that if we don't tell people what we're doing and why we're doing it, it's very hard to get buy-in. And ultimately, if you don't have buy-in in a process, particularly, I mean, for anything medical, but particularly if we're talking about therapy, if we're talking about rehab, we don't have magic solutions. There's not a pill that you're going to take that's going to get you from here to here. It's just work. So education is foundational to how we get people invested in doing the work. And then kind of also building off your point, like, we're not going to go out there and run a marathon today. We're going to take 2 steps today, but seeing how each of these incremental wins and knowing that it is a process, it's going to take time. It's going to take longer than you want it to. But if you just keep moving forward a little bit every single day, then you can get there. And that you have a whole team of people around you who's going to help you. Like, no one in this process or in the situation should ever feel like they're alone, like they don't have a partner, like they don't have anyone on their side. Like, no, you should be, if you are in rehab, you're surrounded by a team of people who are all pulling for you. And so how do we all figure out how to communicate well, work together, get on the same page about things? And I think then we can support some really, really strong outcomes. And then I think what I would add to what you said in terms of we're working with people who have dementia or other kinds of cognitive impairment or whatever it is, how are we can't change that person. What we have to do is think about how we as a team or we as individual providers are working with and approaching that person in order to make sure that their moment-to-moment experience, because they are probably living in a moment-to-moment time frame, right? So what can we do to make sure that their moment-to-moment experience is as positive as possible, even if it's not always pleasant, right? Like if I'm helping you get up and you're hurting, it might hurt. And sometimes there's not a whole lot that I can do to take all of that pain away. But how can I still make you feel, how can I make this person feel supported? How can I make them feel cared for? How can I make them feel like I'm not here to torture with you? Like this is something that we're doing together. And that I think is something that we can do, even if someone has dementia or they have other cognitive impairments that make it difficult to understand like the big picture of what's going on, really focusing on creating a lot of positive experiences for them moment to moment and really working together as a team to make sure everyone's on the same page about that, how that happens. Because, and I'll say, I don't know what the research on this is. I don't, but I do think that even if we don't have like explicit memories of things, and even if people who have dementia or other memory problems aren't laying down new explicit memories, I think that experiences make an impact, and that those experiences, if they're positive or they're traumatic, can like leave an impact on that person, even if they're not consciously aware of it. So I think that sometimes we have to do a better job as like a healthcare team and a healthcare system to make sure that we are creating those positive experiences as opposed to unintentionally sometimes creating traumatic experiences for folks.
Yeah, I think that's really, really key right there. I think sometimes it's just, I think we get so used to taking care of people who are cognitively normal or able to interact with us that we forget how much slower or how different or how we might need to think outside of the box for people who are living with dementia. And like using all of what we know about this person as a human, like remembering who they are as a human, sometimes that connection can help, get people to participate more, using their family and friends, like in whatever creative ways we can. Yeah, I think that's really powerful what you said.
And I think that those are like the things that we could do in our best case scenario, right? We talked about like communication and motivation and education and all the chins at the end. But like part of my education, sometimes depending on the person's personality, is telling them how horrible it could be if you don't do this, right? And so, okay, now I'm putting it to you, Dr. Lamb. So let's say we pick the worst case scenario. So y'all did the right thing. Everybody did all the things they could do at the acute level. It's fixed technically, but because it's a hip and it's so painful and it controls, you don't go anywhere without your hip. So it controls whether you're moving or not moving. So let's say we can't move, or we not can't move but don't want to move, or I feel like we're in too much pain to move and we're just like not escalating at the rate that we should. What are some additional complications that might happen at home, or things that could happen after having a hip fracture that might send them back to see you in the ER?
Yeah, I mean, I see a lot of times people who haven't moved who then fall again. That's something I see pretty often, especially people who don't want to go to rehab, or they leave early, they're upset, which not all rehab places have a wonderful reputation, which is like a whole nother thing. So, but I feel like another fall, but I feel, I mean, clots are like a big thing that I see, like when people don't lay around, they get clots. And then, I mean, I I can't remember actually the last time I resuscitated someone from a pulmonary embolism who was after a hip fracture. I don't think I've had anybody that like was coding in the ER from it, but I've diagnosed lots of pulmonary embolisms, blood clots in the lungs. And then if they're big, that puts stress on the heart, can cause heart damage. And so then like you can have this just cascade of just the person not recovering. And, you know, and it's usually not just one thing, right? It's like multiple things that add up, like all these little medical things that add up, and then they make it so something happens that just tips the scales. And, you know, maybe it's infection, maybe it's a bigger blood clot. And, you know, people, a lot of times we wind up transitioning people to comfort care because they're just not doing well. And that would be what their wishes were. So, yeah, it's tough, but I think clots are a big deal. And then other falls when people just like aren't moving around.
And so a lot of this just comes down to like that seemingly basic thing of mobility, that when we don't move, then it can cause this series of kind of like cascading catastrophic failures until things are really, really not going well for a person. So moral of the story here is we have to get up and move.
Our bodies are made to move. Our bodies are made to move. They function because we move. We don't move because we feel good. We function because we move. And so that's why it's so important that we move even a little bit, like just a little bit more each time, right? Because our bodies are made for that. And nothing works well if you don't do it.
Yeah, nothing works well if you don't do it. Sorry, go ahead.
Oh yeah, I think also like just to plug prevention here, you know, like we all do, it's like pay attention as you're aging to going to see the doctor, doing your like bone density, and like continue to do weight bearing exercises, and don't ignore that, you know, and it hurts, like it hurts to break a bone. It's uncomfortable. And who knows if you fall and you break your hip. Listen, I've seen people that have broken their wrist at the same time, broken ribs at the same time. So now you don't just have one injury you're trying to rehab, you're also trying to recover from these other things, which can make it more complicated. So it's like, don't ignore that. And advocate for working with you all, you know, anytime we're worried about someone who's at increased risk of falling, that we do whatever possible in their environment to decrease that risk and to increase their mobility and their functional abilities. So prevention is key here, but it won't always happen. These things are extremely common. So
yeah, and that's like why there's such a big, I don't know, I feel like when I encounter clients, they're always like, oh, yeah, keep from falling, prevent from falling, but like it's not made up out of nothing. And it's not just about getting dings from Medicare at a hospital level of falling. It's really more about the outcomes are like what you said, like you fell and had a hip fracture, and then the main reason you see people come back is because they fell again, right? And so like if we could have prevented the first fall in the first place, we might not have had any of those cascading effects, right? And that's why like prevention is so important, and like thinking through the multiple ways to decrease falls that there are.
Oh, and medications. Look at the medications. Make sure you're not being over medicated, because that can cause falls too, especially for people who are aging. It's like, always don't forget the medicines. So.
And we've had like a talk on the podcast about like deprescribing and like finding ways to have less medication. And so if people haven't heard I think it's the first episode we had with Reshma. Who's a pharmacist. But if they haven't heard that, can you just give people a few little tips about how they can initiate that process of reviewing meds and like considering which ones need to go off? Because it probably shouldn't be done the way some people I know do it, which is like, I don't know what this means or what it's for, I'm not taking it.
Yeah, so I think the first thing, and it's kind of annoying, but is just like gathering all the medications a person's taking and actually coming up with an accurate list of them. And then next to that, each medicine, it's like, what is the purpose of this medicine? If we don't know what it is, we need to figure it out. And we need to know what the plan is for each medication a person's taking. It needs to be serving them a benefit. Like, we shouldn't just be taking medicines because we're taking them indefinitely. Like, it needs to actually be benefiting a person to take a medicine. So each one needs a purpose, a plan. 5 or more medicines, and we really need to ask for a medication review. I mean, you can do that at a primary care doctor's visit. Another thing I would say is be really wary when you go to see different specialists, because these days, like, the doctors aren't always communicating with each other and their notes don't always communicate. So we can't always see that someone else added on a medicine. So, like, it's up to us to be the champion of our own health and wellness. We obviously need to draw upon the tools of the medical community and all, but like, if we need to know what medicines we're taking, we need our own list. Like, we need to be the owner of the list, right? Don't trust the computer. And then if you're advocating for another person and you're involved in making their medical decisions, like, just like you would protect your own self with medicines, you need to do that for them. Like, you need to know everything that they're taking and why they're taking it. So, but be wary of people adding on things, also adding on things for symptoms of other problems. So, but 5 or more medicines. And I would say, like, really, it's time to, like, make sure that these are all serving a purpose and they're not treating side effects of other things. So polypharmacy is like the main, like, one of the buzzwords, like, it's a real problem. Too many medications, basically. And then deprescribing. If somebody doesn't believe in deprescribing, then I don't know. They may not actually care. They may not actually care about patients. So, yeah, that's all I'll say about it. I could talk about that for a long time.
So, to kind of, like, I think we've gone into a lot of different areas for this topic. I think, hopefully not in too overwhelming a way, but kind of to sum up, final thoughts here. First is the best thing to do to avoid, the problems that come along with having a hip fracture are to do fall prevention in your own life. And we know we can prevent so many of the falls that occur through things like medication review for polypharmacy, through things like home modification with an occupational therapist, through things like regular exercise, socializing, engagement in meaningful activities. Make sure you get your eyes checked and your glasses updated. Like, these are things that we can do that are actionable, that we know are incredibly effective to help prevent us from having that fall and that hip fracture in the first place. So if you haven't had that, if you're not there yet, like, use some of the doom and gloom that we spouted on this episode, because we spouted a fair amount of it. It is scary. And you know what? If that scares you a little bit and it motivates you to go out and take some preventative action, then great. Use that motivation to go and take care of that now. And on the other hand, if you are in a situation where someone has already fallen, maybe they're in that rehab process, or maybe that's even you and you're sitting there, use this as motivation to say, like, are there some scary outcomes? Yeah. But do they have to be that way? And the answer is no, absolutely not.
Get moving.
Sorry?
No, get moving.
They
don't have to do that. Get moving.
Get moving. We have great outcomes all the time. You just have to get up and do the work. All right, guys.
I think we care about that.
We care lab. We care lab the heck of it. Brandy, take us home.
If you made it all the way to the end of this episode, we are grateful for you, and we'll be even more grateful if you leave us a review and rate us too on the podcast platform or YouTube where you're watching or listening to this at, because then other people who need to hear this message can get that as well through the algorithm. So like and review us, and then leave us a comment, because we always want to answer your questions and care lab them. So let us know. We love the feedback. And then come back and see the next episode of Care Lab next Friday.
All right, we'll see you next time right here on Care Lab. Oh, thank you, Dr. Brittany Lamb, for being here again. We sure do appreciate you. You're amazing.
Anytime. Thanks for having me.
All right, next time, guys. Bye.
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 This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.